Microsatellite instability and its role in pathology. A comprehensive exploration. Welcome to today's podcast, where we delve into the intriguing world of microsatellite instability and its profound implications in pathology. Let's embark on a detailed journey to understand this critical biological phenomenon and its significance in cancer diagnosis and treatment. Understanding microsatellite instability. Microsatellite instability, often referred to as MSI, describes a state of heightened genetic mutation within certain short, repetitive DNA sequences known as microsatellites. This instability arises due to a malfunction in the DNA mismatch repair system, a complex mechanism responsible for correcting errors that naturally occur during DNA replication. When this system fails, errors accumulate within these repetitive sequences, leading to changes that can drive cancer development. Origins and causes of microsatellite instability. Microsatellite instability can originate from two main sources. The first is sporadic, often accounting for the majority of cases. Here, the malfunction arises from epigenetic changes, such as the silencing of the MLH1 gene through promoter hypermethylation. This is commonly seen in tumors such as colorectal, gastric, and endometrial cancers. The second source is hereditary, most notably associated with Lynch syndrome. In this scenario, individuals inherit mutations in genes responsible for mismatch repair, including MLH1, MSH2, MSH6, and PMS2. Lynch syndrome follows an autosomal dominant inheritance pattern and presents an increased risk for developing colorectal, ovarian, and urothelial cancers. How pathologists detect microsatellite instability. There are two primary methods used in clinical laboratories to identify microsatellite instability. The first method employs polymerase chain reaction-based testing, where DNA from both tumor and normal tissue is compared across specific recommended markers. Depending on the number of markers found to be unstable, tumors are classified as having high, low, or stable levels of microsatellite instability. The second method is immunohistochemistry, which assesses the presence or absence of mismatch repair proteins within tumor cells. A loss of these proteins, such as MLH1 or PMS2, often signals underlying microsatellite instability. These diagnostic approaches are crucial not only for confirming the presence of microsatellite instability but also for screening individuals for hereditary cancer syndromes like Lynch syndrome. Furthermore, the status of microsatellite instability provides important prognostic information. For example, colorectal tumors exhibiting high levels of instability are often associated with improved survival rates. This information also guides treatment, especially in determining eligibility for immunotherapy. The effects of microsatellite instability in cancer biology. Microsatellite instability drives cancer by increasing the mutation rate within tumor cells. This hypermutated environment generates a rich array of new antigens, unique protein markers, making these tumors particularly visible to the immune system. As a result, tumors with high microsatellite instability are frequently infiltrated by immune cells and show a remarkable responsiveness to therapies that target immune checkpoints, such as inhibitors of programmed cell death protein 1 and programmed death ligand 1. In terms of specific gene targets, instability can cause frameshift mutations in crucial regulatory genes, such as transforming growth factor beta receptor 2, BAX, and APC. These disruptions contribute to uncontrolled cell growth and cancer progression. Microsatellite instability across cancer types. Microsatellite instability is observed in a variety of cancers, each with distinct characteristics. In colorectal cancer, approximately 15% of sporadic cases and the vast majority of Lynch syndrome-related cases exhibit microsatellite instability, often presenting as right-sided tumors with mucinous features. Endometrial cancer demonstrates instability in about 20 to 30% of cases, with Lynch syndrome-associated cases frequently involving mutations in the MSH6 gene. Gastric cancer show instability in up to 20% of cases, and these tumors often have a diffuse histology and a relatively favorable prognosis. Although less common in prostate cancer, only about 3 to 5% of cases, microsatellite instability in this context tends to indicate a more aggressive clinical course. Therapeutic implications and future directions. Recognition of microsatellite instability has revolutionized cancer therapy. Immunotherapies, such as pembrolizumab and nivolumab, are now approved for the treatment of solid tumors demonstrating high microsatellite instability, regardless of the tissue of origin. Response rates for these treatments are particularly high in colorectal cancers. On the other hand, tumors with high microsatellite instability may exhibit resistance to certain chemotherapies, such as fluorouracil, but may respond better to alternatives like oxaliplatin. Looking ahead, universal testing for microsatellite instability in all solid tumors is increasingly recommended by clinical guidelines. Researchers are also exploring combination therapies that pair immunotherapy with targeted agents, and even the development of vaccines for hereditary syndromes like Lynch syndrome is on the horizon. In summary, microsatellite instability serves as a critical biomarker resulting from defects in the mismatch repair pathway. It drives mutation, shapes the tumor's immune environment, and profoundly impacts diagnostic, prognostic, and therapeutic decisions in oncology. Testing for microsatellite instability has become standard practice in colorectal, endometrial, and a growing list of other solid tumors, opening new avenues for personalized medicine and improved patient outcomes. Thank you for joining us in this episode as we explored the fascinating role of microsatellite instability in human pathology. Stay tuned for more insightful discussions in our upcoming episodes.